What's up, everybody? Welcome back to Nursing Uncharted, where we delve into all different types of nursing specialties and search for uncharted conversations. I'm Maggie Reichard, pronouns she, her. I'm a medical ICU nurse and former traveler, and your host for this podcast. I am also 34 weeks pregnant right now, and I think we're probably a few weeks out from when this airs, so I'll likely either be 9 months or 10 months pregnant, depending on when she wants to come out. So this episode has been on my bucket list for a good 8 months now, selfishly because I want to get an inside scoop on what to expect when I go into labor, but also because it's a huge specialty and we haven't covered it yet, and it is labor and delivery. So L&D. So here to give me the inside scoop on L&D is Meighan Pribesh. Meighan graduated from James Madison University with me in 2014 with her BSN, and she went right into labor and delivery nursing. She's been working in labor and delivery for a little over 8 years now, and she spent most of those 8 years in a high-risk labor and delivery unit at a large academic hospital, and then recently relocated to a small community hospital after meeting her fiance. So she knows a little bit about both worlds. I'm excited to get into how that might be different. And she's getting married soon also.
Yes, so 1 month tomorrow.
Crazy. Meighan, welcome to the show.
Hi, Maggie.
How are you doing?
Pretty good.
Thank you so much for coming on today, talking about labor and delivery. You were the perfect person for it.
That's all I know. So.
Did you know that back in nursing school, did you know you wanted to do L&D?
I knew either NICU or labor and delivery.
Okay.
So I did both, like my externship, I did NICU, and then for nursing school, I did the L&D one, and I was like, okay. I was like, let's see what I'm going to pick, and there was actually a hiring freeze in the NICU, so it kind of made my decision for me, and I'm very glad it did, because I feel like it's the pace I needed at the beginning of my career.
Yeah, I kind of, it's interesting how, like, you know, those first decisions will propel, the rest of your nursing career. Like, I got my first job on the unit that I did my capstone on, and I was there for, in neurosurgery for like 3 years, and like, I got my CNR in like neuroscience, and like that's my background. That's I
can't say I regret it. I think I'm right where I need to be.
Yeah.
I've like gone to help on other units, and I'm like, ooh, no, that is not for me.
Well, good for you. So I don't think I've ever told this story on the podcast before. I don't know if we did our L&D clinical together, but I passed out hard on my L&D day. The day that was for deliveries, I was with a woman who had a C-section. It was a planned C-section, but I remember talking to the mom and the dad before we went in. And the dad, like, I was kind of cutting it up with the dad, and the dad was like, oh, are you going to pass out? I'm like, no.
No.
Foreshadowing. And I was in the OR, like, you get all, kind of scrubbed up and sterile and everything for the OR. And I'm not doing anything. I'm just, hanging out in the background. I'm, like 5 feet away from anywhere where the action was. And there was another nursing student with me. And, I remember like being in the OR and them like cutting to the uterus and like smelling the cautery. And I remember being like, oh, this is really cool. Like this is, the nurse is right up there with OB, like telling them where to go and where to cauterize. Like maybe this is what I want to do. And then they're like, clear. And then they cut through the uterus and the baby comes up, and I immediately feel my blood pressure like drop. Like, and I was like walking around the OR, like, like trying to like get my blood pressure from not like tanking. But I was like, I know my blood pressure is low, so I didn't have very far to go before I like completely passed out. But I like left the OR, and then I like walked into the corner of a wall. I like hit my head. It was a whole like it was a train wreck situation. And
it is a sight to see though. The pulling is what got me on the first one I ever saw. I was like, oh my gosh.
Yeah.
What the heck? I mean, you don't even think that can be a thing, and the two surgeons are like, oh,
yeah.
Great.
Well,
I did get a little hot. I didn't pass out, but it is something that you're like, you have to get used to, I feel like. It's not like, oh yeah, it's normal.
yeah, for sure. Well, I think that just goes for like all OR surgeries, just in general.
Oh
Like,
yeah.
when you get, as a patient, you get put to sleep and you just like don't even think about like what's actually happening. It's like, it's like they're getting in there. Like they have to
Mm-hmm.
move things out of the way to get where they need to go. And
Everyone always thinks, I've heard so many moms be like, so they just take my insides and put them to the side. And I was like, no, they don't do that. They're not sitting on the table next to you while they get the baby.
yeah, right.
But some people do want the clear drape. That's like a thing some hospitals offer now for a C-section. And I'm like, you can just hold the baby over the drape for me.
Yeah, right.
I don't want to see all that.
I think that would be, for me, I feel like that would be kind of like dissociative. I would be like,
yeah, like what are they doing?
Yeah, like I'm not connected to, like I don't know what's happening to my belly right now. I think I would want.
Right, and you're trying to get excited about meeting your baby, and you're like, ugh.
Like what's going on down there?
I wouldn't. I personally, even having seen it so many times, would not want to see that.
Yeah.
Like, just show me my baby when it's out. Thank you.
Yeah. Yeah. I don't know. Well, I want to talk about, I know, so you were in this high risk environment, this, academic hospital, and then you've moved to kind of a small community hospital. Like what has that change been like for you in L&D? Like, do you feel like there's a lot of differences, or is it roughly the same? What has that been like?
I'd say probably very different.
Really?
Because, so the first hospital is that we had like 300 to 400 deliveries a month. So that means in one shift, like I've seen 12 babies be born in a 12-hour shift. Whereas at my new hospital, we could have 5 babies in a week.
Okay.
So it's very, very different. But also at the first hospital, there were 10 to 13 nurses on, where it's just me and one other nurse.
Okay.
So that can be scary in an emergency, that you only have one other nurse, and if you have other patients.
Yeah.
You're like, okay, who's helping me?
For sure.
So a lot more involvement of like the patient care supervisor and manager and things like that, where the first hospital, like the highest hospital, there were almost always other nurses. They were busy too, but you had hands. You're like, poke your head out the door like, hey,
yeah,
need some hands. So that is the biggest difference, because I'm so used to the volume.
Yeah.
And I was like, oh, we've gone 3 shifts and haven't had a baby? Like, this is weird.
Yeah. So it's a different workflow a little bit.
Yeah, so that's very different. But I also greatly appreciate that at the Highers Hospital, it was more like a machine. You're like, all right, get the baby out, got my hour recovery, I'm getting my next patient, whether you're ready or not. Whereas here, it's not like that. So I can like really get to know my patient, work with my patient. And we have to get them over to the other side after about 2 hours, but it's not like hard pressed, get ready for your next craziness. So I really love that, because I feel like my patients get to know me. I can like really work with them. Whereas before, like I said, it was like, okay, are you okay? Got to run to the other room. And it was more like a machine. I started to feel a little bit robotic. Like you're like, okay, check, 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 versus like making each experience unique for the patient. So that I do love. And I think the third biggest difference is having physicians and anesthesia always there, versus now I do not. So there is one physician out of 3 that she stays there pretty much no matter what. Like she'll run home to let her dog out and come back. But even if there's no patients, she stays there.
Wow.
The other 2 do not. But that's kind of nervous in a L&D world, because, anyone can come in and have a baby in 2 minutes. Or, so it's like, okay, you have to remember that phone call amidst trying to admit somebody and help the mom. You're like, did somebody call?
Did somebody call?
So we have a doctor here.
So are they normally, like, do they rotate out at that smaller community hospital? Or, like, it's like an on-call situation where when they're there? It's
like an on-call. So for about, I think they each do 24-hour shifts, like on-call. So they'll be in the office, which is just like a run away from the hospital. So if they're at the office during the day, they can get there really quick.
Okay.
And then, like I said, overnight, one stays, the rest are within 20 minutes. But you have to think, they got to get out of bed, get dressed, get in their car. So that part is a little nerve-wracking. And then the weekends, they pretty much take a whole weekend. So Friday, Saturday, Sunday, that same physician will be there.
Okay. But if you have like 5 births a week, then they're aware that this person is here, like ready,
Here.
like.
Yeah. Yeah. We keep them up to date, like as soon as someone comes in, but there's instances, like I said, somebody comes in, they're 7 centimeters, and like as the nurse, without the residents putting orders in, which was a luxury I've learned, I have to put an order in to even send blood down. So you're like, okay, I have to put the orders in, get the IV started if they want pain medicine. Is their baby okay? Get the doctor here. And it's so that little part is a little bit more heated at the smaller hospital, which you would think would be the opposite, but there's so much more help at a larger hospital.
Yeah.
So a lot more autonomy, I guess, in good and bad ways.
I've seen that. I think that translates to a lot of different specialties too. Like in smaller community hospitals, you have more autonomy sometimes, in the sense that there are less hands to do things, and so a lot more things fall on the nurse, or like orders and things, like when you want a certain workflow to flow well, and like the doctor's not there to put orders in because they're just not in the hospital, you just kind of get used to it. Like I think a lot of travelers that come in, are surprised at the hospital that I'm at now, because they're like, can I do this? I can't do this. I can't just like put this order in because
it's hard.
Yeah.
I never even knew, we'd put an occasional Tylenol in at the big hospital, but the residents, like, they're learning and they want them to do it. Yeah. So they're like, please don't help them. They need to learn. So you're like, okay. And then here I was like, wait, I have to do all that. Because like a C-section is another thing. Like a lot of C-sections, unless it's a elective C-section, you need to move. Like it might not be like pull the cords out and run, but within 30 minutes, like there's a reason we're doing this. Mm-hmm. So when we sat one day and made that list of every single step we have to take, and you're like, also call anesthesia, call the other scrub tech in, call the doc. That alone, I feel like takes 5 minutes of your time. Yeah. And like I said, it's only me and one other nurse. And like there's 2 other nurses on the floor, but if they have patients, it's really hard for them to come help. Yeah. So that's where the patient care supervisor at night and then the manager during the day can assist a lot with just little things that are a big deal for us because it's one less thing for us to do.
Yeah. You said nurses on the floor. Is that like mother baby?
Yes.
Pretty much.
So we, at the community hospital, it's mother baby and like GYN and some overflow from the hospital. When they're super full, we get like hip surgeries, knee surgeries.
Gotcha.
So it's a very wide variety of patients over there. And sometimes there's just one patient and sometimes there's like 5 couplets. So essentially 10 patients.
Oh my gosh.
So they've got their hands full sometimes too, and it's like, okay, who can break away and come help?
Yeah. Do you normally have to float over there, or are you generally L&D only?
At this hospital, mainly L&D. It's where I prefer to be, honestly.
Yeah.
Some people prefer the other side. I prefer labor. And now that I can actually work with my patients and apply like positioning and stuff that I never really got to delve into, I want to do it because I'm like, it's almost like magic. Some of the stuff I've learned, I'm like, man, I did not know that for 8 years. I'm so mad at myself. Because if I would have just known to do like XYZ, I could have, maybe saved somebody from a C-section. And I've actually seen that a few times where like nurses have worked all day to get somebody to 10 centimeters. And then I come in and do some position and I'm like, oh, it worked. It's like, it really is like magic that I didn't know about until a few years ago.
That's wild.
So it's fun.
Yeah. I'm sure that comes with experience and like just keeping up with I don't know, like, do they teach that stuff? Or is it more so like, you
kind of have to go out on your own. They just started offering spinning babies is what it's called. And the hospital actually paid for a few nurses to go last year and this year. And the crazy part about it is it's supposed to be like a 5-day course, but since it's become so popular, they've condensed it into a 1-day, like 8-hour course.
Wow.
But it's overwhelming. Like trying to learn all of that and trying to remember all your anatomy and physiology from 8 years. I'm like, oh, what nerve? Like what muscle? So trying to do all that in 1 day was difficult. And it's like, I think I would have gotten more out of it if it was longer, but I'll take anything I can get to try and help the patient.
Yeah.
So I would definitely love to eventually go to like a conference because they do those for the spinning babies and learn more from different people too.
Yeah. Oh, I'm sure there's L&D conferences all over. Or there's got to be
Yeah,
like a
which those are
national
things.
one.
Yeah, they do that. And even this specific spinning babies, they do like a conference for that in different areas and different speakers come. So, and everybody has their own ways. And I've learned that even like doctors stick to their ways. And sometimes as things evolve, they're like, mm-mm, this is my way. And
Yeah.
it's hard coming from a resident program where everything was like new and upcoming. Every research thing that
Yeah.
came out, they're like, we're going to apply this to working with physicians that have been there for 30 years who are like, this is how I do it.
Yeah.
And you're like, okay, let me stand back and they know what they're doing.
Yeah. I'm sure, yeah, that's probably a big difference between smaller community hospitals and academic hospitals too.
Yeah, I think that was another challenge just when I got there because I was like, ooh, okay. And you have to learn to kind of like reel it in, but then you also have to know when to stand up for your patient safety.
Yeah.
So it's like a fine line between, okay, I can just stand back and not say anything here, but sometimes I really just need to say, okay, this has changed.
Yeah. We don't do this anymore.
We don't do that anymore.
This is the evidence. This is the evidence-based practice.
Yeah. So that's hard. But
Yeah.
I've like grown to see what each physician likes, and that's another thing. Like three physicians liking very different things. You're like, okay, which one they like this, like they like you almost need like a cheat sheet on the wall.
Yeah.
Like this physician likes this. So that's harder, especially for people that are new nurses coming to learn. Because they're like, wait, like yesterday when I did this delivery, they wanted this. And I was like, you basically just have to ask them.
Yeah.
And don't be ashamed. Just say, hey, what would you like? Because if you want me to do it the way you like it, I have to ask till I get used to it.
Yeah. Yeah. I've heard that a lot well, is that particularly in the OR, or do you feel like that's just in like L&D in general? Because I've heard of that in the OR particularly.
And it's, I guess, more so in the delivery. That they like things done differently. And like right after the baby comes out, you start Pitocin. But one likes it when the shoulder comes out, one likes it after the baby, and one doesn't like it until the placenta is detaching. So it's like three very different things. And I guess they're all okay because they all do it, but it's just like, oh crap, or like I started it too early for this one. And you have so many things to do as a nurse at that point, and that's what I try. And as I've gotten more experienced and comfortable with my skills, I'll speak up. Be like, hey, I know you really like this, but I have 3 other things to do.
Yeah.
So I need you to be patient. Whereas when I was a new nurse, I wouldn't dare like have the audacity to do that. But now I don't do it in a mean way, but just like, I don't think you realize what I have to do at this time. No. Can you please hold on?
Yeah.
And a lot of them are receptive to it. It's just like, they're like, oh, I didn't know you have 90 other things to do right now.
Yeah.
Okay.
That's like, yeah, when anybody wants to do any procedure, it's like, okay, I need to get the sedation. I need to get the pumps. I need to like do the checklist. I need to, make sure that I have, like, we have to call respiratory. Like, there's
it's not just
you
like,
can't just show up with your supplies. Like, there's a
You're
lot
ready,
of other
but
things that need to happen, like for intubation. Like, we need to,
Yeah, and we just experienced, I don't know if they were up there or not already, but we got new pumps about a year ago that linked to the computer, which people might have had way before us. But let me tell you, that has been like a whole learning curve because, like I said, right after the delivery, we get the Pitocin started. But when there's 95 clicks to get that now, the physician's like, is it started? And you're like, no, I can't figure this thing out. Or the internet's not working, so the scanner doesn't work today or whatever. Little things like that have proven to be the most difficult parts of my job lately.
I've heard, so that's interoperability. Oh, God. Interop. That's what I call it. Interop.
Yes, I was like.
With like where they have like the QR codes on the yes. I have learned to love Interop, but it's because I don't even look at the pumps anymore. I mean, as long as the channel has to be, you have to make sure that it's scanned and that it's like, communicating with Epic, because if it's not, then it just like goes into like a automatic, like it just thinks, you know, if you're
sometimes it just turns off too. I didn't
Yeah.
like when we first got them, I went in the room and I was like, uh-oh. Like there's nothing that signals that my pump turned off. And like in labor and delivery, we typically only have like LR and Pitocin. But like in the ICU, if one of your pumps just turned off, that's a big issue.
Yeah.
So that's why I was like, how do they, I mean, along, like in due time, I'm sure they'll figure out a way to let us know. But I was like, ooh.
They're probably like update changes, or like if it's like a channel error, sometimes you'll get that. I haven't had that happen. Thank goodness I haven't had that happen yet. Like that would be very bad if it's like a pressor or something, just like all of a sudden turn off. But I mean, the fact that you can just go into flow sheets and put your volumes in. Mm-hmm. I mean, that
I did think, I was like, that's awesome for ICU. Yeah. Like to keep track of everything. I was like, we just don't have that much to hourly kind of stuff.
Yeah, that's true.
So unless they're on like a high risk med, like magnesium, we do hourly, like eyes and nose, but typically we don't. So I was like, well, this is nice, but probably more nice for other units than us.
Like it's really just more of a hassle for us.
Yeah, and a lot of my nurses have been there for 20, 30 years. So switching to Epic a few years ago was a big deal, but now the pumps are another deal. And sometimes it's just like, I'm going to manually do it and it still works.
Yeah. I mean, at the end of
the
day, as long as you're doing it right, you know, it's trying to take away human error. If you're getting more human error because of the pumps.
Because of the pumps, yeah.
You know, reevaluate what's going on. We'll be right back to our interview. Grab a cup of coffee, but don't go anywhere because we want to talk to you about our podcast partner, American Mobile. No matter your specialty, American Mobile has endless travel nursing opportunities. With the largest clinical team of all staffing agencies, American Mobile is ready to support you in achieving your career goals. To learn more about the benefits of American Mobile, like higher earning potential, premium health coverage, and 401k matching, make sure to visit AmericanMobile.com to speak with a recruiter. Again, visit AmericanMobile.com to discover your next travel nursing adventure. Now, back to the show. Well, I want to get into kind of like the logistics of L&D and your job, and like, so what is your normal, so I'm guessing 12-hour days. What's your normal assessment look like? Or kind of map out your day for me.
Okay, so basically, either hospital, we kind of cover what's on the floor. And high risk, we divvied it up. Each nurse had their own patients. The smaller hospital, we kind of do a lot more teamwork.
Okay.
Because if there's just one patient and 2 nurses, we both take care of that patient.
Yeah.
So we kind of figure out who's going to do what. And then we'll go see our patient, check off our medications, and try and figure out with a labor patient where they're at and like what problems they're facing. So are they progressing normally? Are they not? Have they been 4 centimeters for 12 hours? Like what can we do differently as a new team to try and get them that baby? So that is what I really try and like, and I like to feel their cervix myself. That's another thing, like physicians don't love it, but like as the nurse and I'm going to be positioning the patient, I want to know exactly what I'm feeling. Like, is there more on one side or the other? Should I be positioning them this way? Is the baby coming down right?
Yeah.
So I like to feel that early on, if it's safe. Once your water's broken, we try and keep our hands out as much as possible so that, but sometimes I'm like, the benefit of me knowing what I'm working with will really help the whole rest of the day.
Yeah.
The head to toe is pretty simple because most of the patients are healthy. So I was like, the biggest like out of normal limit kind of thing we see is swelling.
Yeah.
That's really it. Like swelling is pretty much the only thing we're like, is it significant or not? Other than that, they're normally like heart, lungs, everything are pretty normal. Yeah. So we listen to them, every 4 hours, but that stuff usually doesn't change unless like with high risk patients, if they're on like a magnesium drip or something, we assess that hourly. Just like lungs and swelling and reflexes. So that's a little bit more intense with the assessment, but generally speaking, it's more that cervix. And then fluid is another thing we pay attention to. So when they break their water, if there's meconium fluid, like that's something, gotta let the pediatrician know. They need to be there at the delivery. and kind of just watch. The heart rate is what people don't realize. We have a whole separate like fetal monitor screen. So not only do we have the mom, but we're constantly looking at the baby's heart rate all 12 hours.
Mm-hmm.
So like even if you go pee, you think, okay, like it'll be fine for 5 minutes, but anything can change in 60 seconds. It can go from beautiful to not. So you kind of have to communicate with other nurses like, hey, run into the bathroom, or even like eating lunch is like, there are monitors in the break room at the bigger hospital. So lunch is not like, let me lay back and eat my lunch for 30 minutes and not pay attention. You still are kind of looking. Yeah. You're like, okay, is my baby okay? And a lot of times you'll have somebody out on the floor, you know, watching. But they can get busy too. Yeah. Sometimes you get back and you're like, hey, how's my baby? And they're like,
oh, I forgot I was even listening for you.
So that makes it a little bit harder because it's not just the patient in the room, it's the patient inside of the patient. Yeah. So that I would say is what makes us a lot more different than other. It's just like, I mean, tele though, like when you have a patient on tele, that's very different than one that's not. Yeah. Because you have a whole other aspect to look at. So looking at that, just even if the baby starts to look bad, you're looking at, okay, I need to go change her position or turn off her Pitocin. And that's when you get stuck in a room for a good amount of time. Because if the baby is not starting to look better, you're like, okay, are we going to be able to fix this from our like few interventions from the outside or not? And then you're looking at the operating room, which, like I said, at the big hospital, there's always everybody there to do that. Smaller community hospital, you've got about a 30-minute window to get everybody there that you need to.
Gotcha. So when you start to see heart rate changes, you turn the Pitocin off?
That's usually like the last thing I'll do. So we go from like least invasive. So side to side is usually very helpful. And then oxygen used to be used a lot more when I first started in my career. And then they kind of have gone away from it because they're like, if the mom is satting 100, is that oxygen truly going to, you know, help?
Do anything, yeah.
And so I think they have found in due time that it's not as effective as they thought once before. So it's almost like the last thing that we don't even do it most of the time now. So the side to side change. And then a lot of times, like after the epidural, your blood pressure drops. So like, okay, fluid can fix that. And even sometimes the baby just needs a little boost. So we'll give like a 300 bolus and see if that helps. But if it's something that's recurrent and you're like, okay, I've turned you, given you a little bit of time, and it's still not helping, we will turn either half it or turn it off.
Okay, gotcha. And what is I should have asked this before, the intervention that you were going to that course for, spinning babies, like what is that?
So that is more so when the baby is coming down. So like say you were 2 centimeters and we broke your water, which some physicians like to do that, but others don't, because you're getting that baby stuck how it is at 2 centimeters. And if they're not in a good position to come out, that lack of fluid there is kind of keeping them more that way. So, and it's very hard. You can tell the baby's head down, you know, at 2 centimeters, but it's really hard to feel their position. And you can feel your, you know, the belly and everything. But really, truly, once the baby comes down, you can feel their sutures and everything and know exactly how they're positioned. So spinning babies helps try and get that baby aligned with the pelvis to have a more successful chance at a vaginal delivery. And sometimes you do get stuck at like 3 centimeters, and it also helps maybe like, okay, maybe it's the baby's position that's doing that. So they teach you a lot of different ways to work with the mom to get the baby in a better position for delivery.
Gotcha. Okay.
So because like sorry.
No, go ahead. Go.
I was like, my last shift, I did everything I possibly could and have ever learned, but the baby was almost like transverse, like asynclitic, not coming straight down. So there's nothing we could do. Yeah. And we had to go for it. And she had room in her pelvis and everything, but that baby was not lined up, and no position was changing her. She liked where she was at. So sometimes no matter what we do, and it's not the patient's fault, it's not our fault, but the baby just was coming down the wrong way.
Yeah. I had a friend who after she delivered and we saw him, he loved to put his arms like right next to his face. And he was totally doing that in utero, and it was like so hard to get him out because he just
No.
he would not get his
Not do that,
hands
yeah.
away from his face. And it's like,
Sometimes they'll sneak like a limb, like they'll come out with like a compound presentation. So kind of like that, and that makes it more difficult for sure. Sometimes you can push through it. Sometimes I will never forget one time there was a baby who got his hand out ahead, and literally you could see it.
oh my
Like you
God.
could shake the. We were like, well, that means we need to go to the
Like,
OR.
grab
What
my
the
hand.
heck?
Like, no,
Yeah,
that's
we
not
went to
how we
check
do
her, and we
this.
were like, oh boy. So to the OR we went, but they do lots of funny little things. But the best thing is to make sure when we go to break someone's water, or when the physician does, that the baby is well applied to the cervix, and that prevents a lot of issues from happening.
Sure.
Because if the baby is super high up there and has room for anything to slide under the head, like a hand or a cord,
Oh, yeah.
then we have an emergency.
Gotcha.
So we try and prevent that at all costs, but sometimes someone's like will not progress, and the only thing we can do is break their water and see if it helps.
Yeah. What are some other like emergency situations when we were talking about the cord?
Yeah, so cord prolapse, somebody's hand's right on up there, and you have to ride to the OR, and really until you like touch the surgeon's hand. Like from below, you'll be there, and so that's like, I mean, not fun for the patient, not a cool emergency, but it's a cool moment. Like you're like feeling them take the baby out. That's probably like the number one. I do not like emergency at my job, but you don't see it often, thank God, but it does happen. An abruption, so the placenta detaching is another thing. And sometimes there's like a partial abruption, so you'll see a little bit more bleeding, but you're able to still have a vaginal delivery. But a full abruption, like if you notice it soon enough and get to the OR and get the baby out, but that's I think the number one reason I've seen like IUFDs, like intrauterine fetal death.
Oh, okay.
It's from an abruption. So somebody with really high blood pressure that's not under control. I literally had a patient, and I will never forget. You have a lot of abdominal pain, and your belly gets really hard. And she called. She was in a ton of pain, had no bleeding, got on the ambulance, was in the elevator, and in the elevator ride up said she got super faint, started having bleeding, and got to the unit, and the baby was gone. And so we don't have a way to say that that's when it happened, but from her story, it sounds like that's when like the total abruption happened, and that is so hard.
Yeah.
Because you're like, I mean, and that's when every minute counts. So where I said at the like high-risk hospital, if we notice the baby's heart rate's down and that's what's happening, you can get to the OR and have everybody there like really fast. Where in a small community hospital, no matter how fast you want to work, you have to have the surgeon and anesthesia there.
Right.
So that's probably, I said, even delivering myself, like, do I want to drive 45 minutes and deliver where I know there's so many more resources I'm comfortable with, or do it here? And most of my coworkers have delivered down here, like, no problem. But being that I worked in a high-risk facility with everybody there all the time, I was like, I think my anxiety will personally be
nice to have those
less
resources at your disposal. Yeah. I was kind of wondering, I mean, being an L&D nurse for so long and seeing how all the different ways that things can go down, like, has that changed your, thought process on like how you want to have your babies like in the future?
Yeah. I was like, I sometimes wish I had kids before I became a nurse, because
you're like, I've seen
like
too much.
Like you said, I know anything and everything. And even like my friends that are pregnant, when my best friend was pregnant, we were out shopping one day, and I don't know, I was talking about the baby moving. She's like, I haven't felt her move. And I was like, how long has it been since you felt the baby move? Because she's just like a willy-nilly, I don't care kind of person. And I was like, has it been 2 hours? Has it been 4 hours? Like, when's the last time? So I think when I'm pregnant, that stuff will alarm me way more than someone who doesn't know. And like right now is like I have a family member who is pregnant, and she is very hyper aware of things too. I was like, oh, is that going to be me? Like from the minute I find out, am I going to be that kind of person, or am I going to be a little bit more laid back? And I think when you're around the resources to like ultrasound your baby real easy, like are you going to want to do that? That kind of stuff. But then it's like most people go weeks without monitoring and they're fine.
Yeah.
So it's a little bit, I don't know, I guess until I'm there I won't know.
Yeah.
But I've had coworkers be both ways.
Mm-hmm.
Some are like so laid back, and I'm like, how are you like that? Because I don't think I will be that way. But I definitely think as of like, if I got pregnant tomorrow, I'd want to deliver at a busier facility.
Yeah.
Only because I also know most of the staff there too still. So people that I worked with for 7 years, like I could handpick like who I would want to be there with me.
That is true. That's a great perk.
And keep me calm, because some nurses are way better at keeping somebody calm than others. Mm-hmm. And I know exactly what kind of personality would work well with me versus like, please get away from me. So
yeah.
I don't know. I like maybe in a year from now too, I may change my mind. After working here longer, I might be a little bit more comfortable, or know enough like anesthesia staff to be like, hey, would you mind spending the night here while I'm in labor?
Yeah, that's right.
Because I felt like I got that relationship with people at my other job. I felt like, okay, I know enough people that would hang out or even probably come in on their day off.
Yeah.
But I've only been at the new hospital for a year, so it's not like, I mean, they would have my back, but it's like people for 7 years really know me. So
yeah, I'm sure. I mean, those are probably like the. I mean, you're such a special patient when you work there, like on the unit, and then you're.
And I feel like everybody's like really hyper focused. Like, is their baby okay? And so I will say, taking care of like other coworkers and friends is a little bit anxiety ridden, because you're like, okay, I've been doing this forever, but if something goes wrong, can I be a nurse and a friend?
Yeah.
So I was like, my best friend had twins, and I got her labor started and then went to lay down for an hour, and someone else took over and then like was there for the delivery. And so that was the best case scenario, because I just got to be the friend holding the leg in the delivery.
That's awesome.
And was the nurse for the first part. Because I was like, if something bad goes down, you're going to lose a nurse. Like, I will not be able to do it all.
Yeah. Oh my gosh, so true. I know I'm delivering where I work, and I'm going to be like, okay, if I go into labor, I'm just going to go upstairs. Like go up.
Right, right there. And that's really nice too. Like that you're right there.
Yeah. Yeah. I know. I'm like wondering, people are going to want to come visit. I'm going to be like, I'm good.
That is a hard part. Yes. I actually delivered an ER nurse from our hospital, and all of her coworkers wanted to come up, and I was like, no. Like, if you guys want to visit her tomorrow or the next day when she goes home, like, sure, but this is not just an open door policy because you work here.
Yeah, right. Like, I got a badge.
Nor does the patient want that necessarily, but then, there's like, you feel bad. You're like, oh, like, how do I tell them? And I was like, I'll be the mean person. Like, I'll tell them, no. Like, you cannot come in here. And, like, people want that time with their baby.
Yeah.
That first few hours is so special, and I feel like a lot of people feel guilty for not having family members in there and things like that. And that's where, as a nurse, I always say, like, I will be the bad guy. You can blame me. Tell them Meighan said no, because you can't get that time back.
Yeah.
And the baby's going to look the same the next day in all reality. Like,
right.
The baby will be exactly the same the next day.
Yeah. Do you feel like you are put in situations a lot where you have to be like the patient advocate?
Yes, even when it comes to doctors too, because I feel like, as a patient, you're going to say whatever the doctor says. So there's times where you have to let them know, like, I think one of the biggest areas I see this is when somebody wants an epidural. Like, if they come to break their water after that, it is like 0 to 100 for most patients. So if they know they want an epidural and it's a planned, breaking of the water, I like to get the epidural prior. Because afterwards, you're going to, like, literally in a matter of minutes, be writhing all over the place. Some people are acting crazy at that point. And so I'm like, why even cause that? Like, let's just do it in this order. But for, time management purposes for the doctor or whatever, sometimes they're like, well, you can just get it right after.
Oh, so they want to break their water and then get the epidural.
And then let them get if it's like, and I'm like, no.
Yeah, like, let's do this first.
That. So I kind of tell the patient to, like, say no.
Yeah.
Say, nope, I'm going to get my epidural and then do this as long as it's safe.
Yeah.
Because no one should have to go through that if they don't have to. And, like, it's very easy to not be the person in the room with them and say, oh, yeah, you can get it right after.
Yeah.
But if you're the person in there with the patient, you will know that that is not what you want to see or
Right.
they want to feel. So that's where I'm like, I'm the person in here with them. So
Yeah.
no,
Yeah.
like, let's go ahead and get it scheduled, or like talk with me throughout the day as when you want to do this and we can have it done for you.
Yeah.
And so I try and really, I love in-person communication way better than phone communication.
Mm-hmm.
So I will go to the office. And when I worked with residents, a lot of people would just call them on their little phones. And I was like, no, I'll walk to the office, because the more we feel comfortable in an uncomfortable situation, we'll be able to address each other.
Yeah.
And I learned that it took me a long time to get comfortable with that. But I was like, well, since I see you every time I want to talk to you, you know me, you're comfortable with me. And if I didn't like what you did, I have no problem telling you that.
Yeah. That's very true. That's really great advice. Because it's
I
like,
feel like the phone is you're like, okay, I've heard this person on the phone so many times, but do you really know them?
yeah, because it's easy. I mean, that's the easy thing. The easy thing I feel like is to just like quick call or like send them a
Mm-hmm.
text, like, whatever kind of communication you use. But actually, like, you're developing rapport at the same time when you're
Yeah.
talking to them face to face, and you can put a face to the name, and then you're on a first name basis. And then like,
Yeah.
it's,
And it's nice because sometimes with residents, they'll come to you for advice.
yeah,
Like, they'll feel a lot more comfortable because, in all honesty, like a first year resident versus a nurse of 6 years in L&D, like, you can learn something from me if you
yeah,
utilize me, but sometimes they just have a complex that's like, I'm a doctor and you're a nurse, and that honestly does not work out for the best of anybody, for the patient or anybody, because it's constant like battle.
yeah,
Whereas the ones that have been open to like befriending nurses and working well with them, I've noticed are like much better doctors after the 4 years.
yeah, yeah, for sure.
And they trust you in a time where like there's three patients they need to go see, and they're like, oh, you can go check the patient's cervix because I trust you.
Mm-hmm.
Whereas if you don't have that, that's a lot more work on their plate that they have to get to, because they might not have enough people that they trust.
Right.
So that was my biggest thing as I learned. I was like, you know what? Let me go talk to them in person. It might like impede their charting or whatever, but it actually helps so much more at the end.
Yeah, in the long run, absolutely. That makes so much sense. I was talking to an attending recently about the relationship between interns and nurses, because sometimes it can be a hostile relationship. Like when the nurses are expecting, a certain level of competency in somebody that has not been doing this for very long, and there's a certain level of grace, I think, that sometimes you have to have for the interns that like we don't always give to them. And it's a give and take. So like sometimes like, and then those interns get callous that they're like, being belittled by nurses, and then it creates this long-term rift between interns and residents and nurses, where the residents feel like they have to like push their authority, and they might not know like the best thing, but because they're the doctor, it's like what they say. And it's like, are we, perpetuating that by bringing in this kind of like preconceived notion that the intern isn't going to be able to do what we want them to do? Like we're setting that up. We need to be better, I think, in fostering that relationship first, when they come in. And I think that's something small, just face-to-face communication as opposed to calling, that probably goes so much farther than you even think.
Yeah, my relationships with residents as I did that were so much better, and I felt like even like outside of work, like we could all go get breakfast after a shift. And that was something where you get to know those people's like outside lives. And so at work, like maybe you didn't know that somebody's been trying to get pregnant for 5 years and can't, so they might have a bad day at work.
Yeah.
But you're not going to talk about that while you're running around in your first year trying to get all your stuff done. But when you get to know them a little bit more outside too, I feel like that it really loosens up that communicate. Like you're like, okay, hey, you could do this better. Whereas 2 weeks prior to that, they would have been like, oh, thank you for telling me that. So
Yeah.
I feel like that really helped. We started doing that. Like the chief would say, like, "Oh, does everybody want to go to breakfast afterwards?" Like nurses and residents, whoever would want to go. And the more we did that, it was like such a more like friendly, light environment.
Yeah.
And I never felt like it hindered us, like our work in a sense.
Yeah.
Because some people are like, well, if you become too friendly, and I was like, no, like we worked really well together. And even in times where I didn't agree with them, it was no big blowout. It was like, hey, can I talk to you? And will you sit down and explain it to me? And I learned a lot that way,
Yeah.
having them sit down and talk to me versus a phone call of, I don't like what you did.
Yeah. Yeah. That's such a good idea. I think we tried to do that, and it's hard. It was hard during COVID because it's like, okay, we didn't want to, get together, outside of work. But like now I feel like that's something that we could totally start implementing again.
Yeah, I think they do. Like I said, I'm not at the other hospital as much, but I think they almost do like a little like brunch even at the hospital, like have donuts and coffee and like kind of let everybody mingle so that they get to know the new faces that are there.
Yeah.
Because otherwise it is, like you said, so easy to be like, oh, it's July and
yes,
4 or 5 new people that don't know what they're doing coming, can't wait.
Mm-hmm.
Because that's like the busiest season for labor and delivery is usually summer, so we get all new faces in the busiest time. And then like how much can you really get to know somebody when you can barely get your job done in the 12 hours?
Right. Yeah, absolutely. Yeah, you gotta try to do that work outside when you can in a fun way.
Yeah, some fun always helps because, like I said, at the teaching hospital, like stress levels were very high, and I got a lot of gray hairs from it. I learned a lot, but it was definitely a lot. Even as a new grad, I will say, like it is like a dog eat dog world. You either come in and you make it, or you very quickly know it's not for you. There's no like. It's very rare that you see somebody come in and be a certain way and change completely. It's kind of like in the first month.
Yeah.
Can they handle it or not?
It's not for them.
Sometimes you have to tell a orientee that, which is hard. But say, hey, I've worked with you for a while now, and I don't think this job is for you.
Yeah.
And it's hard, but I'd much rather them know that early on than get a year into it and be like, man, I'm still not getting it. Because it's for some people, and it is not for others. Even shift work, I feel like night shift is for certain types of personalities, and day shift is. So
yeah.
I feel like you learn along the way what fits your personality.
I've been in that situation before where I've had an orientee. I don't know if I was on their team. Maybe I like had them for the day. This was years ago, but she was not cut out for inpatient work. She just like worked she really wanted to establish a rapport with patients, and like we've been saying, like in a like high trauma 1 level facility, it's you really have to prioritize your time well. And I just remember like being with her and like getting report, and we talked for I want to say like 10 minutes about the pain scale, like in giving somebody report, and I was like, this is not, we gotta keep going, honey. Like this is, or she commended me on the way that I like closed the Pixis drawer. I don't know. I was like, okay, we gotta, and I think we had to, ultimately tell her. Yeah. And I think she is happier, and she works outpatient now, and I think that she is doing much better there. But it's a hard conversation to have.
Starting outpatient and trying to come into the hospital is hard because I feel like your first job, like you said, it kind of shapes you, and so if you're used to one thing and then you're like, wait, what is this life? Like it's, and even if I would have started at the hospital I'm at now and tried to transition to the high risk facility, I would drown.
Oh yeah.
Like I would not even know which way to look, because there's been a few busy nights where my coworkers are like, man, this sucks. And I'm like, imagine if every single shift was like this. I was like, it really does. Like, I mean, it's like I said, for a certain type of person to work it, but it takes a toll on you as much as you like try and keep up, like seeing so much and doing so much, you realize like, man, I just need like a breath of fresh air after so long.
In kind of bouncing off of that, do you feel like there are some misconceptions within labor and delivery? Like when people come in, to start in like L&D? And, do you feel like there's expectations or difference between expectations versus reality in the job?
Yeah, I think the biggest one is the rainbows and butterflies kind of thing. Like, oh, it's labor and delivery, and if you hold babies, and I'm like, I do, like, very rarely do I get the chance to cuddle a baby, and it's if we're really slow and the mom needs a nap. But they kind of think like, oh, I'm gonna deliver the baby, it's gonna be cuddly and happy, and I'm like, you've got to remember, especially at the high risk facility, like these moms are sick. Like they are really sick. Their babies are coming sometimes like 15 weeks early, which sounds crazy, And so you not only have to do your job and sometimes like, run high risk medicines, but you have to be there for somebody who's having a baby that's going to be in the NICU for months. So trying to figure out how to do your very stressful job and be there for the patient, and then the losses that happen. A lot of people don't think about like, oh, I might have to deliver a baby that's not alive. You don't, like in nursing school, I feel like I never even let that cross my brain because you don't really hear about it. You hear about early miscarriages with family members or friends, but like a term baby is, somebody had their nursery, they had their baby shower, they had everything. And now what?
Yeah.
So, and as a nurse, I will say it takes years to get used to it in a sense.
Yeah.
Like that first term baby, like holding a baby that's 8 pounds, that's not alive, like that is a very hard thing to do. But in that moment, you have to try and get it together and be there for that patient and almost go home and recap or call a coworker or something that was there maybe to try and talk to them. But I think debriefing is huge and it gets missed a lot because there's no time.
Yeah. I'm sure that never gets easy.
No, I was like trying to digest it. And that's another thing that I think some people learn they just can't do.
Yeah.
Like I personally, I had to see a dead adult once. And that was very hard for me. I was like traumatized. And they're like, can you help us put her in a body bag? And I was like, what?
Yeah.
Like, no, I cannot. You have to find somebody else to do that. I don't do that. So whereas like an ICU nurse, that's like a normal thing, like, oh, okay, like, I can do that. So I think you just have to remember that everybody's specialty is different and every day is different, and try and really just realize, do I want to deal with these situations? Because like, obviously it will get hopefully easier as you go, but some people just realize early on, like, oh, I didn't even think about that aspect. Like, I don't like that.
Right. Yeah.
So that's the biggest thing. I think people are always, oh, you deliver babies. And I'm like, yeah, but every day is not great.
Yeah.
And like with the sick moms, like seeing somebody, like labor is hard just being labor.
Normally. Yeah.
But then imagine like if your blood pressure's through the roof and you're on magnesium, which makes like all your muscles relax and you're swollen everywhere and you have a like 10 out of 10 headache and you're at risk of a seizure, like that makes labor so much harder.
I cannot imagine eclampsia.
And being stuck in the bed when you're like on a magnesium drip, you cannot get out of the bed.
Yeah.
So that first part of labor where a lot of people like to get up and move or be on the ball or even do that part at home, they don't have that option.
Yeah.
And so they get cranky.
Oh, I'm sure.
But you have to like kind of put yourself in their shoes. And the reason I wanted to become a nurse was because my dad was in the hospital for so long. And ever since then, I always try and, even if a patient is like on my last nerve, because it happens, like people will get under your skin and or you have them for 3 days in a row and you're like, oh my goodness. But if that was my sister, how would I treat them?
Yeah.
Or, my best friend, or however you have to put it in your mind, like, let me just think of them that way and like how I would want to treat them. And that's when I get a little jaded and I'm like, okay, over this, I try and think of that to try and like get me through.
Just find some way that you can be empathetic towards.
Because it gets hard. Some days, like everyone's so different. Some people don't make a peep and some people scream the whole time and you're like, oh my goodness gracious.
I wanted to, like, what are some of what are patients that you like working with the best? Asking for a friend.
I was gonna say, I think somebody, not that you have to read books before you come in. But like if you want a natural labor,
Mm-hmm.
that you did your research.
Yeah.
Like you don't just come in and you're like, I don't want an epidural and I've never looked into any ways to breathe. Because that is frustrating because I'm like, I can't teach you that during the pain.
Yeah.
So if you have a little bit of okay, this is what I read, not that you can recall all of that, but this is at least what I know. Or I want an epidural and I know like I'm not going to be able to eat after that because some people get so mad. Like I was like, I know you're pregnant and not hungry, but you can't eat. And people will get so mad at you like I made that decision to piss you off. And you're like, no, like it's just the rules.
Yeah, I'm sure it's probably well, when I think of challenging patients in L&D, I think, we all think about what our baby's births are going to be like and like have an expectation, and then it doesn't go according to plan. And I feel like the nurse is probably right in the middle of that, like caught,
Yeah. I think almost going in, this sounds crazy, but with no expectations. Because when people come in, and I hate to say this, but when they come in with a 5-page birth plan,
I was going to ask about birth plans.
We almost always joke that those people go to the OR.
Oh no.
Like, honestly, the amount of times that I have seen that, it's like a ticket to the OR. Because people just, like I said, they come in with unrealistic expectations. Like, there are definitely things like cord clamping and skin to skin. Like, those are almost routine now. Mm-hmm. So it's not like we will totally do what you want, but to a certain extent.
Yeah.
Like, there's some things that just aren't realistic. And do not come in and not tolerate a cervical check and tell me you want to go natural. Because that is unrealistic. Like, that you don't tolerate pain well. Just admit that, okay, I'm at least open to the idea of an epidural. But then I was like, when I do have a natural mom who comes in and she's prepared, and it's a mindset. It truly is. Like, you have to spend months telling yourself, I can do this.
Yeah.
Because when people do that, they come in there and they rock it, and it is amazing. Like, there is not a day that will go by that I'll watch a mom unmedicated and not be so proud.
Aww.
Because it's crazy. You're like, I don't know if I could do that. And even with epidurals, people think it takes all the pain away.
Yeah, and it doesn't.
They're like, oh yeah, nope. No, I'm like, no. That's not realistic either. Like, pressure is a thing. Mm-hmm. Like, you will feel your belly get tight still. It just won't be like, ouch, like there's sharp pain. Mm-hmm. So that's all. People always think, well, I can still move my feet. I'm like, some people can lift their legs, and it is great for all of us, because when you push and I have to hold your leg for 2 hours, I will love if you can lift it. But as long as your belly feels better, it's great. But not every epidural works.
Yeah.
And that's a reality too, because, everyone will be like, oh, my friends work great. She didn't feel anything. I'm like, but you can't think that's going to be your situation.
You never know.
And the pressure of a baby being down there is no joke. Like, it's like we always tell people when they're pushing, we're like, just like if you had not pooped for 2 weeks, like imagine like that feeling. I was like, and that's how and then a lot of people are like, I don't want to poop. And I was like, if you're pooping, it's exciting for us because you're using the right muscles. Yeah, right. Like it's the only time in life you'll ever hear somebody be like, yes, great, it's okay. And the nurses are really good about like not letting it be everywhere. Yeah. You may not even know you did it, but it's a lot of pressure regardless of an epidural or not, and it does not feel good. So I always tell people, I was like, it's going to get worse. And I don't lie to patients. I'm not like, oh, you're going to get epidural and it's going to be like great until the baby's out. Yeah. Like, nope, it's going to suck for a little bit, but think of that baby coming out as like my number one thing to patients, because when they can like envision that, I feel like they get a lot more strength. Yeah. Or like get angry at the end, like get mad, because honestly, like that's how you push the best.
Yeah.
So like I have found that I'm like, okay, just get really mad. And like a mirror sometimes. Yeah. Some people are completely against it. But if you can see your baby's head, like this much of it.
I've heard of that.
That's exciting.
I've heard that's
like
motivation.
When you're like getting tired.
Yeah.
And you can see that. Or some moms want to feel like the baby's hair. They're like, oh my God, like that's my baby. And then you're like, okay, I'm going to get this baby out. So as gross as it sounds or whatever, it's like a motivating factor for sure.
Yeah. Oh, I'm sure. I know. Yeah. I've heard that before, that mirrors are very, very helpful.
And you won't remember anything else you see besides your baby's head. I was like, a lot of people are like, I don't want to see that. I'm like, you're not going to even probably have the thought process to look around it. Like, you're just going to want to go, can I see the head, please, God? Because we constantly tell people, like, you're doing good, not that much longer. And they're like, after an hour, like, okay, you have told me that for
like,
an hour.
Yeah, right.
And so I'm like, so the biggest thing is a first time mom, like, it's a marathon. Like, pushing is not, well, for most people, some people are really lucky and push 3 times and they're very lucky. But a first time mom can push up to 3 hours and it's normal.
Yeah. Oh.
And that's a lot of effort. So if you do get an epidural, sleep.
Mm-hmm.
Because a lot of people will be on their phones or they'll have visitors. And I'm like, honestly, this is the time for you to get your rest because you need every single bit of it that you can get to get that baby out.
Yeah, absolutely. I'm kind of in a boat. I think my whole mantra, like for this whole pregnancy is just, or like in my expectations, I just want her to come out safe. Like that's like, I'm trying to keep expectations low. I have been preparing for a natural birth, but I'm not saying like absolutely not to an epidural. Like if I need it, I know that like there are, it can be magic.
Right.
And, like,
yeah.
So I'm just kind of, and it's like, I'm going to prepare for this mindset of, going natural, but I'm ultimately like, I'm not going to get mad at myself or like,
yeah, like you said, safe baby, safe mom is our number one goal. And I have to remind patients that sometimes when they get real mad or angry, I'm like, look, we are doing this for you and your baby to be safe at the end of the day. When I'm not doing this to torture you or cause you pain or anything like that. And some people get frustrated because, like I said, turning is like our number one intervention. And to be honest, it's what gets the baby down. So the more you move, the better. If you just stay laying, flat for 12 hours, that's not helping anything.
Yeah.
So people will be like, well, you've woken me up. Or we come in to move the baby monitor because we can't hear the heart rate. I'm like, look, I do not want to be in here every 5 minutes any more than you want me to.
Yeah.
But we're doing all these things for you to have a safe baby.
Yeah. Right.
And healthy baby. And so that is one thing I appreciate when patients are like, oh, it's okay. Like, I know you have to do that.
Yeah.
Because when they get mad at us, I'm like,
like,
I'm sorry, but I really can't. I have to come in here unless you want me to chart like patient refuse.
Refuse to hear make sure my baby's okay. I understand.
Isn't that great?
I mean, I see both. I see both camps.
And I feel like once I'm a patient one day, I probably will understand it on a whole new level. But a lot of my friends have had babies and they still think the same way. Like, they're like, okay, like, I had to go through this too. It's not always great, but you have to go through it.
Yeah, it'll give you a whole new, like, way to connect with your patients too.
Yeah.
When
I have one of my coworkers has had like a singleton. She's had twins, 1 vaginal, 1 C-section for her twins. So she had both worlds there. She has been on like a magnesium drip, a labetalol drip. And so she was like, if anybody ever complains, she was like, I can truly say I have been through it all and you will make it. Like,
yeah, they will come out.
Make it.
They will get them out, hell or high water. Well, is there any advice for new nurses that might be interested in L&D? Like, what characteristics do you think might make a good L&D nurse?
Well, first I would always shadow before you do it.
Yeah.
If you have the opportunity, in a lot of hospitals, even if you work on a different floor and you want to go there, or your LPN, they'll let you go for a few days and make sure that you like the pace of it. You like the people that work there. Because like I said, it's crappy to get all the way there and then be like, oh, this is not for me. But I think it takes a very like strong-willed and outspoken in a sense. Even the quietest nurses that work on labor and delivery have to have a voice. Yeah. Because like I said, you have to speak up for your patient and you actually have to speak to your patient in a stern manner sometimes. Which is hard, and people tell you don't think of a nurse doing that, but like there are times where I just like grab my patient's face and I'm like, do not listen to your mom, do not listen to your husband, me and you, that is it. Like, and you have to be willing to do that, and it comes with experience. Yeah. Like, I know you're not going to walk on labor and delivery and be like, yeah, I know everything, but very open to learning because there's new things being released all the time on how to help our patients. Like the positioning thing, like I said, it's become really big in the last like 2 years for me. But like a lot of people, like once you get set in your ways, you would never be open to that. So like open-minded, strong-willed, and like I said, willing to be outspoken. Like you don't have to be sassy all the time, but you have to have that in you somewhere. Because I have noticed that very like quiet, timid people that might be great in a like an ICU setting where they don't have to talk to the patient as much. In L&D, you are constantly talking not only to the mom, but like to her husband and her mother that's there, and having to guide everybody through like, why have they been 3 centimeters for 12 hours? So you're almost always having to explain things to multiple people.
Yeah.
And standing up for your patient and helping them through really hard times. So if you're not a people person, not the place to go.
Yeah.
Because you are with that. And like I said, I try and take patients back. Like if they're there for a 3-day induction, I try and take them back. So I really get to know that person. And you're in there pushing, just keep this in mind, for an hour to 3 hours. And there is quiet time between each contraction. So if you don't know how to talk to people or aren't willing to, it gets real awkward.
Yeah. Oh, I don't think about that.
Like 5 minutes to just stare at each other. So when you really get to know someone, I feel like that time is super easy.
Yeah.
And you can distract them and make them feel good and relax during that time. Whereas if you don't have that like personality, you may not love that part of it.
I feel like a lot of that can be learned. There's personality, there's like people that just have a knack for it. But like as far as like the backbone thing, I for one did not have a backbone when I came into nursing, and now I have a backbone. And it's definitely something that you have to acquire. And
I guess be willing to get there.
Yeah.
Is where I was trying to get. Because like if you're not willing to expand on your personality, then and you're like set, like I'm a quiet person and that's how I am, then probably not the best place.
Yeah.
And like I said, it's hard, so you have to be able to handle your emotions. Because I've had nights where I have a laboring patient in one room, and then I have a patient who lost her baby in the other room, and I have to take care of both of them.
Yeah.
So your mindset has to be so different, and your words. You can't be like, oh, I need to go turn that mom because her baby's heart rate's down.
Yeah.
Because that patient will be very upset with you when you leave.
Yeah, right.
So emotions are a big thing that you have to have under wraps as far as labor and delivery.
Yeah. Yeah.
And that comes with time too. But if you're someone that does not care at all about, like, you're just kind of like, with emotions, I wouldn't say.
Not good for you.
Go deal with a pregnant mom.
Not going to be therapeutic.
To deal with all sorts of emotions during labor, a person changes so much.
Yeah.
Like someone that you've never heard cuss before, you're like, oh, I didn't know they had that in them.
Yeah. Yeah. I mean, the different stages, right? Like the first stage of labor, you're like, early labor, you're like joking in between contractions. And then
once they get in transition, like 8 to 10 centimeters, you're like, some people are very, very different. I'm like, oh my God, I'm so sorry afterwards. But we don't even think twice about it because we know, like,
baby's coming.
Yeah, so you cannot get your feelings hurt about that.
Yeah.
Or even if a patient doesn't like you, okay.
Yeah.
I'll find, like, and I was like, here's another nurse, but like at the smaller hospital, you only have 2 options here. So
yeah, and we both think the same. Yeah.
So that's hard, and because if you don't match with your nurse, it is hard. Like 3 days with people that you don't mesh with, I can imagine making a labor experience very different.
Yeah.
For somebody who loved their nurses.
Yeah. Yeah. Absolutely. So like establishing good rapport and just being able to be personable and,
Yeah. And find out about the patient. Like, don't just go in and do your assessment and leave.
Yeah.
Because I feel like some people do that. And it makes it a lot harder when they get to the hard parts of labor. If you know a little bit more about them, you can help them through that way easier when you know a little bit about them.
Yeah.
Like, even what their job is.
Sure.
Like, tells you a lot about somebody. So you can be like, okay, well, let me relate it to this or whatever. So I really try and get to know without being, like, too nosy,
Yeah.
like let them kind of guide where I go with it, but get to know them as much as possible.
Okay. Oh, I'm so excited to meet my L&D team in a couple weeks.
Like I said, when you if you love them, like everyone says that an L&D nurse they love makes like the world of a difference.
Yeah. Oh, I'm sure. I mean, they're in it.
And tell them what you want. Make sure you tell them. Like I said, 5-page birth plan. We don't want to say we judge, but we're like, oh gosh, when we see
now
it.
I'll know. No, my birth plan's short. It's short.
My favorite birth plan ever was a patient. It was like 2 sentences, and it was like, please deliver a safe baby and have a Dr. Pepper waiting for me afterwards. It was like a really like sweet, like,
oh my
please
God.
just get my baby out safe, and I want a cold soda after. It was so funny. We all laughed because she was like, here's my birth plan. And we're like, oh boy, let's see what this says. And then I was like, oh my gosh.
That's cute.
We can do that.
Oh.
Yeah.
I'm going to take that. I told Matt that I really want sushi. I cannot wait to eat raw fish. I'm like so excited for it. I'm going to put that in my birth plan. I want her to come out safe, and I want sushi when she's out.
She's out in the fridge waiting for me.
I want sushi in the fridge waiting for me. Awesome.
And that will get you through too. Like some patients really want like a cold Coke afterwards because you only can have like sips of water throughout. So I'm like, all right, get this baby out. And I like literally have it waiting on the counter for them with ice, because those little things will get you a long way when you're tired.
Yeah, something to look forward to. Oh, well, this was an awesome conversation. I'm so happy. I think that we covered a lot of L&D ground. You were perfect for this, so thank you so much for coming and talking on the podcast with me today.
Absolutely. And congratulations early.
Thank you.
I'm excited
so
to
much.
see pictures.
Oh gosh, she's gonna be here before I know it. All right, I'll talk to you later.
All right.
That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubin and Sam McKay, and Aiden Dykes for the music and editing. Until next time, take care of yourself.